Hey, it's Dr. Centeno, and today we're going to talk about stem cells for degenerative disc disease and discogenic pain. So here's what we'll discuss. The basic science of regenerative medicine for discs, what we know about the use of various orthobiologics, and focus on our experience using culture-expanded mesenchymal stem cells for degenerative disc diseases, and the use of platelet lysate extradiscal, and then talk about the future. So what's in bone marrow? There's lots of stuff in bone marrow. Obviously, there are different types of stem cells, mesenchymal stem cells, hematopoietic stem cells. We've got macrophages and other cells that are contributing to a regenerative response. So one of the things that's really critical to understand in looking at this literature is that there's a big difference between bone marrow concentrate and mesenchymal stem cells. Bone marrow concentrate contains lots of cells, as I just showed you, including mesenchymal stem cells. But most of the research to date hasn't been done with bone marrow concentrate, and yet that's 99% of what's being used currently clinically in the disc when it comes to, quote, stem cells. In fact, most of the research has been done with culture-expanded mesenchymal stem cells. So when you see the term MSC, it usually means that they're talking about culture-expanded cells that have been isolated, and these are pure, in quotes. They're heterogeneous, but at least they're more pure stem cells than bone marrow concentrate. And when you see the term bone marrow concentrate or bone marrow aspirate concentrate or bone marrow nucleated cells, that's just an aspirate that's been concentrated. So do we have any basic science research that bone marrow concentrate helps discs? We have zero, none, nothing that I can find. So that's interesting because, again, that's what's mostly being used in the world of stem cells to treat discs. But we don't have any basic science research from animal models to show that you would want to use that stuff. We do have basic science research that mesenchymal stem cells help discs, and here's just a listing of it. I'm not going to go through each one of these, but the bottom line is that mesenchymal stem cells in animal discs, when they're injected, can do good things if that disc is degenerated. However, moving from pigs, dogs, and rabbits and mice to humans is another story. This is a huge leap that we found out the hard way. We tried to replicate animal models that were published in 2004, in 2006 in humans, and it didn't work at all. It was a complete failure. In addition, we've got some pig studies that show robust healing in just saline controls. Quadrupeds are not bipeds, and a stab injury model, which is how most of these studies are done. That's where they take something as big as, for you and I, a ballpoint pen, stick it into the disc and suck out the nucleus, kind of like an alien is taking away your disc, isn't the same as the clinical degenerative disc disease you and I see in the clinic all day. So as you review disc studies, there are really three things to pay attention to. One, saline works well. It likely washes out inflammatory and pain sensitizing cytokines. Two, a general health questionnaire like SF36 is not very specific for changes in function due to spine treatment, and yet we will see studies that use this. And while changes over placebo may be significant, are they clinically relevant versus the cost? And I'll show you at least one study where the changes were really minuscule for an extremely expensive biologic. So we're going to start with bone marrow concentrate, since that's what's used most often. So this is really the only study I know of that's been published using bone marrow concentrate. This is a study by Patine, who's now a retired orthopedic surgeon. This was injected, and bottom line is that there were a few things that weren't done. They didn't use provocative discography, So it's a little less clear who these patients were. They had degenerative disc disease, and about half of them got 1-level injections, about half of them got 2-level injections. What was the most interesting thing for me is a higher CFU content, meaning a higher mesenchymal stem cell content, correlated to the best results. And that makes sense. So 11 out of 26 patients had less than a 50% response, so these weren't perfect outcomes. And there was maybe some change in improvement of the disc, but that wasn't blinded reading, and the change was extremely small within the margin of error for the grades that they used. But in general, encouraging results for people with degenerative disc disease being treated with bone marrow concentrate injections. Again, make sure that you understand another difference, because previously all we had was bone marrow concentrate, but this last few years we've seen a few devices that just use bone marrow aspirate. They are claiming that through this specialized trocar, they can pull out enough stem cells to be able to help you avoid concentration. The problem is all the research we have to date is in fact with bone marrow concentrate and not with bone marrow aspirate, which is what this is. So you can't apply that research now to this technique. In addition, we've performed tests on these devices and they didn't really work as advertised to get high CFU bone marrow aspirate. So just be careful here. If you want to use them, that's great. They may work, but you can't use the bone marrow concentrate literature in talking to these treatments with your patients. Stromal vascular fraction, so that's enzyme digested fat. This was a smaller study, 15 patients. This was fat that they took and they used an enzyme to digest out the nucleated cells, and the patient seemed to do reasonably well. There wasn't really any imaging done. The big problem here is that enzyme digested fat is illegal. It can't be used here in the US right now. So it's an illegal drug product. In fact, this practice in particular was shut down, or at least is in the process of being shut down by the FDA. So we may be able to use this in the future, but right now it's not a possibility. And if you want to use it, put away a couple $100,000 for your legal costs. Cultured MSCs. So these are stem cells that have been culture expanded or other cells that have been culture expanded. So this is the table I put together. The bottom line is, this is the first of 2 slides here in this table, and you can see that there have been a number of case series studies published using everything from autologous hematopoietic stem cells to chondrocytes to mesenchymal stem cells. Most of these studies showed good results. All except one showed good results. There was a double-blinded randomized controlled trial, a small one on the bottom there, that used allogeneic MSCs. And the bottom line was there only about 40% of the patients improved. Some of these studies seem to show changes in MRI, some do not. And these are the final 2 studies of the table. The one at the top there is ours. I'll talk to you about that in more detail in just a little bit. And then I'll also talk to you about the Mesoblast study, which is mentioned here, which was an FDA approval trial, which is now in phase 3, which surprises me because the phase 2 results were not great. So let's talk a little bit about that Mesoblast study. What was really interesting to me about their phase 2 results was that it was pretty unimpressive clinically. And basically, the big question is will insurers pay big bucks? Meaning they only had 40% of the patients that were responding, and this is going to be a very expensive therapy to deliver. They missed their MRI endpoint, meaning that they were supposed to show significant MRI changes like they had in the animal models. They did not. So this is going to be a tough one if this actually hits the market. It's going to be a very expensive therapy with some results in only some patients. So our clinical experience, So what do? We've used both culture expanded MSCs, which are not permitted in the US. We have a licensed site in Grand Cayman where we can deliver that therapy if we need to. That therapy is also now the subject of a phase 2 FDA trial, so hopefully we'll be able to do that here in the US at some point. And we also use bone marrow concentrate. Now, we use culture expanded cells for disc bulges, but we tend to use bone marrow concentrate for those patients with HIZs and intradiscal pain. So let's look at bone marrow concentrate, our experience. Our typical patient has an HIZ and sitting intolerance, has failed epidural and extradiscal PRP and platelet lysate. And that's a key thing I want you to focus on. We treat patients first with extradiscal therapies before we go into the disc. That's very, very critical, I think, for our results, meaning that many of our patients are falling out because they're responding well to epidural platelet lysate and extradiscal therapies. Hence, it's very important to note that in how we treat patients. So this is some of our data here that shows good results with this type of therapy. This is a case series pulled from our registry data just this week. So you can see some very nice results in those carefully selected patients. Again, this is not every degenerative disc disease patient walking through the door. And if you start to use bone marrow concentrate for that, your results are not going to look like this. So let's now talk about culture expanded MSCs. We're going to talk here, this is now a different patient population. Before I was talking about patients who are HIZ positive, have difficulty sitting, classic discogenic pain patients with good disc height. Now we're talking about patients with good disc height but have chronic disc bulges that just aren't responding to epidurals, or at least not long term. So this is an exemplar result here. You can see up top here a nice large disc bulge there. And you can see the axial off to the right. And then the after image, you can see that that disc bulge resolves. Now this is intraannular as much as it is intradiscal treatment, meaning our focus here is to try to repair the annular fibers that are damaged that are allowing the bulge to occur. That's why this is not going to work well if you've got a collapsed disc, because there you've really just got a fibrous disc problem. This is more a hydrostatic disc problem. So this is reduction in bulge sizes pre and post treatment. So you can see some nice results there. These are the SANE scores from the pilot study that we published, N equals 33. So I want to now introduce to you, I think, what will be a very new concept, and that is most of the people using biologics in and around the disc have decided that they're going to inject intradiscal, and I think that's the wrong approach. I think that most of these patients will respond quite nicely without ever taking the risk of discitis and injecting the disc, and that's using biologics in the epidural space, but also in other areas too. So this is a paper we published on this topic, and basically this is another MRI result. This is a more of an acute disc herniation, and you could argue that this would have happened with or without therapy in many patients. We had an MRI right before therapy. We took an MRI 3 months later. This disc had been hanging out a while, so it seemed to resolve due to injecting platelet lysate epidural. Now, what is platelet lysate? Platelet lysate is the growth factor stripped out of platelet-rich plasma, and here injected epidural. And so this is a registry cohort of several hundred patients, and some nice results out to 24 months. And that's what we've seen in these patients, is that this stuff works much better in the same patients that you would use corticosteroid epidurals in, but platelet lysate seems to give much longer term, much more sustained results than corticosteroids provide. These are the functional rating index scores for that same patient population. Adverse events are very minimal, really no different than you would see with an epidural steroid injection. Now, I want to introduce another new concept probably to you, and that is that treating the pain generator versus the whole functional spinal unit. And absolutely critical here that you understand what I mean by the whole functional spinal unit. So this is treating the ligaments. This is treating the facet joints. This is treating epidural and the multifidus, the muscle. So the whole functional spinal unit rather than just one structure. So it's throwing away the pain generator approach, and it is moving towards a very different approach. It's the opposite of what you were taught. You were taught to only find one magic pain generator and treat that. That's causing most of the pain. This is find that pain generator, but then treat more globally. So again, this is high-dose PRP injected into the facets. This is platelet, lysate, and dextrose, so sort of a growth factor augmented prolotherapy for the ligaments. And platelet lysate mixed with nanogram dexamethasone and ropivacaine for fluoro-guided transforaminal epidurals. And this is a data-driven registry project that was pulled together by Chris Williams, MD. We have a fellowship program at Centeno-Schultz, and Chris was one of our fellows. He's now in private practice in Atlanta. And you know, the interesting thing is that what Chris seemed to notice, and this is what we noticed as well, was that if we compared this type of treatment, facets plus ligaments plus epidurals, to just treating the facets, the data sets were different. That you didn't see as robust treatment with just a single structure versus treating multiple structures. And that makes sense because, again, we're focusing here on treating the functional spinal unit versus treating just something like a facet pain. So what does the future look like? Well, PRP and bone marrow concentrate dominate due to lower cost. My guess is that's probably what will happen, meaning at the end of the day, we're going to see a lot of high-cost solutions coming out through the FDA approval cell drug pathway. But the PRP and bone marrow concentrate are probably going to dominate because they are cheaper and they seem to work just fine in a lot of cases. And I think you're going to see some insurance companies balk at the high cost of some of these newer therapies. And eventually, I think we're going to bioprint discs and have them surgically installed. And I think that interventional spine doctors will really need to retrain to treat the functional spinal unit and to learn how to do that instead of just the pain generator. And just some words of caution. Whenever I'm at a big medical conference, I try to throw this in here. You know, we have vendors out there right now in the sales hall, I call it, who are claiming that they're selling umbilical cord or Wharton's jelly MSCs or amniotic fluid MSCs, and we've tested many of these products. These products do not contain live and functional mesenchymal stem cells. Those claims are also not FDA compliant. So this is a scam, meaning that if you're out there in the sales hall and you see someone who claims to have a vial of millions of stem cells they can sell you, not only is that illegal, but it's also not accurate. Because when we test these things with much more rigorous testing, we don't see that. These are dead cell products. I would also like you to consider coming out to the Interventional Orthopedics Conference, Controversies in Orthobiologics, in Colorado in February. This is a fantastic conference where we bring together world leaders from all over the earth to be able to lecture on these topics of using stem cells, PRP, in the spine, peripheral joints, etc. And I'd also like to put a shameless plug in for our fellowship program. We now take 3 fellows a year. You've got to have good interventional spine experience to be able to start this, but the focus is interventional orthopedics, meaning that the ability to place stem cells or PRP or other orthobiologics any place in the body, whether that's the first MTP joint to the tibiotalar joint to the ACL in the knee to the C0C1 joint at the top of the spine, you name it, your focus here is treating those structures with orthobiologics. So this is a very unique fellowship program because at the end of the day, it's the only one I know of where you do 100% orthobiologics all the time. So this is really a fellowship program to prepare you for what's coming down the road. And you're not going to get that in other fellowship programs. The best you'll be able to do is a little bit of PRP and stem cells here and there, and you're not going to get this type of experience. It doesn't exist. So that's great. I'm sure I'll be on the panel answering questions later. Thanks so much and have a great day.